Hello, everyone, and welcome. Thank you so much for joining us today for our webinar, Starting Your Practice in Ontario, a FHO Primer. I'm Meryl Sanassian, the Senior Director of Customer Operations at WellStar, and I will be your host for this session. I'm really glad to see so many of you here. Whether you're just starting out as a family physician, planning your move to Ontario, or considering a transition to a new payment model like the FHO, Ontario offers so many opportunities for physicians. With a growing demand for family doctors and the supportive structure of the FHO model, it truly is a great time to set up your practice here. But we also know that getting started can feel a little overwhelming, especially when it comes to understanding the ins and outs of OHIP billing. And that's exactly why we're here today. This is the first session of our two-part webinar series, where we'll walk you through the fundamentals of the Family Health Organization model, how it works, how to get started, and how to manage your roster effectively. We will also cover important details like bonus payments, ministry reports, and the income stabilization program, so you have a solid foundation as you begin your FHO journey. And I'm thrilled to welcome our special guest today, Dr. Gianluca Calcagno. Dr. Calcagno is a new family physician practicing in Ontario, and you might know him as the creator of the NextGenMD YouTube channel. He's been through this process himself and is here today to share his personal experiences and insights, so you'll get a real-world perspective on what it's like to start a FHO practice. Now, before we dive in, just a quick note. We'll be keeping this session to about 45 minutes, and we'll leave time at the end for questions. As a thank you for joining us today, we'll be sending you a complimentary copy of our 2025 Comprehensive OHIP Billing Guide. To begin, let me introduce you to Doctor Care. Many of you already know what Doctor Care does, but for those who don't, Doctor Care is the largest provider of billing and practice support for over 4,000 physicians across Canada. On average, we have helped doctors recover $25,000 to $30,000 of revenue per year. We also support approximately 25% of all FHOs in Ontario. Our solutions and services are designed to help doctors optimize their practice, maximize their revenue, and improve patient care. Before we jump in, let's quickly go over a few housekeeping items. All attendees are in listen-only mode. We are recording this webinar, so it will be available to you after the event. If you have any questions during the webinar, please do submit them in a Q&A feature, and we will try to answer them at the end of the webinar during the Q&A session. If we are unable to answer your question, one of our team members will follow up with you after the webinar. So let's get started. Over the years, Ontario has introduced a variety of physician payment models to accommodate different practice styles, recognizing that no two practices are the same. The most common model you've probably heard of is fee-for-service, but today we're going to focus on something a bit different, the Family Health Organization. A FHO is a model built around a group of family physicians who work together to provide team-based, comprehensive primary care to their patients. It is designed to support collaboration, improve access for patients, and give physicians a more predictable and stable income. Since its launch in 2006, the FHO model has become a preferred choice for many family physicians, thanks to the significant benefits it offers for both providers and patients. Since then, we've observed physicians increase their earnings by as much as 18% simply by transitioning to a FHO, resulting in more stable revenue and stronger, more consistent relationships with their patients. In this chart, you'll notice the different models of primary care at the top. fee-for-service or FFS, comprehensive care model or CCM, family health group or the FIG, family health network or FIN, and finally, family health organization, the FHO. Well, you will also see the different income streams on the left-hand side. We'll start with capitation. There are two types of capitation payments, the base rate payment and the comprehensive care payment, both of which apply to enrolled patients. The base rate is the main source of income for a FHO. A FHO physician gives up most of their fee-for-service income in exchange for capitation income. With the comprehensive care payment, every patient enrollment model aside from fee-for-service offers this payment. Capitation payments are a significant incentive to adopting a patient enrollment model, as you receive a monthly payment for each patient on your roster, based on their age and sex, regardless of visit frequency. To be clear, if you're a FIG doctor who moved to a FHO, the comprehensive care payment stays the exact same, and you would continue to get it in the FHO alongside the base rate payment. Now, the next income stream is the blended fee-for-service premium. This is an extra fee-for-service payment that you will get when you are in a FIG, FIN, or FHO. In a FIG, it's a 10% premium on certain bills. In a FIN and a FHO, the 19.4% shadow billing is the value received for in-basket billing to rostered patients. Moving on to special premiums and bonuses. These are the annual payments that you will become eligible for in each model, depending on the specific billing thresholds. We'll go into these in more detail a little later. Out of basket, another income stream, is a category of billing codes that are paid out in full value. These codes significantly contribute to billing for a FHO because they are reimbursed in full, even though physicians receive complete capitation for these patients. Next is the classic fee-for-service income stream. All models include fee-for-service. Now with the FIN and the FHO, there is a restriction where a group hard cap of approximately $59,000 per physician is set on in-basket services provided to non-rostered patients. It's also important to know that if you do a lot of billings to non-rostered patients like methadone or pain, the FHO model is usually not the best model for you. For preventive care bonuses, we will go into detail on this later, but the requirements have recently changed for FHOs and a maximum income stream of $4,400 has been set for FHOs. Now, let's break down the FHO-specific compensation structure. FHO physicians receive a form of compensation known as capitation for the patients they enroll. It is a fixed payment based on the sex and age of the enrolled patient, paid out monthly on your remittance advice. You will see two payments on your RA, and they will be named base rate payment and comprehensive care capitation. These two payments make up capitation. The average base rate for a patient is $202 per patient per year, while for the comprehensive care, it's $40 per patient per year. Since physicians receive capitation for their rostered patients, they will only receive 19.4% of the fee value for their in-basket core services to their rostered patients. This is called shadow billing. We will touch more on in-basket and out-of-basket in part 2 of our webinar. For now, just know that billing codes can be separated into two types: in-basket, which are your core assessments and consultations, and out-of-basket, which is everything else. FHO physicians will also receive fee-for-service payments for billing out-of-basket services. This means that instead of the physician receiving 19.4% of the visits they bill when they bill for out-of-basket services, they will receive 100% of the fee value. These out-of-basket services include chronic disease management such as diabetes, smoking cessation, heart failure management, and more. And lastly, there are premiums and bonuses for providing preventive care, prenatal care, chronic disease management, and hospital visits, all of which contribute to the average 18% increase in annual revenue. With this structure, the FHO model offers physicians significant benefits and income predictability. And this is why over 50% of Ontario family physicians have switched to a FHO. There are some additional incentives and premiums that you can expect to bill in a FHO, which further contributes to your monthly revenue. For instance, you can receive additional income if you see newborn patients, patients with chronic diseases such as diabetes, heart failure, and smoking. You can also bill additional codes for seeing patients after hours and for seeing both scheduled and unscheduled patients during your weekend block. We will go into more depth on these fees in part 2 of our webinar series. Now, let's look at the process and the Ministry of Health requirements for getting started with a FHO. Back in April of 2022, the ministry required that all new FHOs have a minimum of 6 doctors in their group, which still applies today. If you are in a well-serviced area with lots of doctors around, like Toronto, it shouldn't be a problem to increase your group to 6. For new FHO formations, co-location is required. If all physicians in a group cannot be in the same location, there should be no fewer than 3 physicians in each location. The distance between the locations must be within a 5-kilometer radius of one another, where the RIO score is 0. The Rurality Index for Ontario score, the RIO, is a measure of rurality that ensures funding is specifically targeted to northern and very rural communities. The RIO basic score is derived from 3 factors: population, so count and density, travel time to a basic referral center, travel time to an advanced referral center. For these areas with an RIO score greater or equal to 1, there will be consideration given to applications from groups who cannot locate within 5 kilometers due to infrastructure limitations or any other relevant factors. All new FHOs must have a shared EMR that provides all physicians in the group access to the medical records of enrolled patients. When a FHO group is about to form, the group should be prepared to operate from the shared EMR on the date of commencement. Now, you may be asking, would it be acceptable to have co-locating offices add each other as users to their current EMRs so that patient records can still be accessed and shared without fully being on one shared EMR? The answer is that it is acceptable as long as when a patient goes into any location of the FHO, the physician they see has access to the patient's record and can pull up the patient information in that location, even if the patient is enrolled to a physician in a different location. Otherwise, the patient could just go to a walk-in clinic. Lastly, each physician should aim to maintain an average roster size of no more than 2,400 patients. If a practice isn't meeting this standard, it'll be given the opportunity to adjust. If the practice still doesn't meet the requirement within the set time frame or any agreed upon extension, steps will be taken to reduce the average roster size to 2,400 patients or another number that is agreed upon by all parties. Now, let's move on to explain the administrative process of forming a new FHO. Once the group has the members and locations, they will need to pick a FHO lead and associate lead. They would then submit an expression of interest. Please note that if they want to apply for the income stabilization program, this is the step they would take. We will discuss income stabilization further later in this webinar. Once submitted, the application will trigger a 10 to 12-week ministry review process. During this time, additional paperwork will be required to formalize the group and assign a group ID. Now, if you are looking to join an already established FHO group, the process is somewhat similar. you would need to approach a FHO group and request to join. In most cases, you would need to be introduced to the group lead for an interview, then a meet and greet with the group, and then the group would need to vote you in. Admitting a new physician and the process around it is laid out in the group governance agreement. You would then commit to and sign the FHO governance agreement. Once that is signed, an expression of interest is completed and submitted to the Ministry of Health. In some cases, if the physician would like to start before being granted signatory status, a locum contract can be completed and submitted. From there, it's a 10 to 12-week waiting period for the ministry to process the application and release the signatory start date. Our team at Doctor Care has helped hundreds of physicians navigate the process of joining a FHO or forming a new FHO. Feel free to reach out and we will be happy to guide you through this process. Now that we've looked at what's involved in starting or joining a FHO group, we want to highlight some of the key requirements specific to FHOs. When you agree to be part of the FHO model, whether that's by joining or creating a group, you also agree to the requirements of what a FHO physician has to offer to their patients, as well as follow recommendations to the best of your ability. A major part of being in a FHO is agreeing to take on after-hour shifts. This includes weekday evenings from Monday to Thursday, as well as some weekend shifts. While that might sound a bit daunting at first, in a typical 6-physician FHO group, it usually works out to about 1 shift or even less per doctor each week. Working after hours benefits both you and your patients. It makes you more accessible, which means your patients are less likely to go to a walk-in clinic, helping to reduce outside use. It also strengthens the patient experience. The more chances patients have to see you, the stronger that patient-physician relationship becomes. The number of after-hour blocks, as they're called, depends on the size of your FHO group. 1 block is equal to 3 hours. You may notice that the chart shows FHO group members under 6. That's typically because of exemptions for FHOs in rural areas. For example, a standard 6-physician group needs to cover 5 after-hour blocks in total, 4 during the week and 1 on the weekend. Your clinic will usually set up a rotating schedule so everyone contributes fairly, and the requirement is met. At Doctor Care, we can take care of your after-hours scheduling as part of our FHO group management services, so you don't have to worry about creating monthly schedules yourself. When it comes to virtual care, as a guideline, each physician is advised to provide approximately 88 patient encounters per week, prorated to a roster size of 1,300 patients. This includes both in-person and virtual visits, with at least 60% delivered in person to maintain quality of care. These targets are assessed at the group level on a quarterly basis and only include services provided to patients who are formally enrolled in the FHO. It is important to note that these are non-binding recommendations, meaning there are no payment penalties or consequences for not meeting them. However, they serve as a helpful benchmark to support patient access and continuity within your practice. Now, I am delighted to welcome our guest speaker, Dr. Gianluca Calcagno. Dr. Calcagno is a family medicine physician working in Southern Ontario. He has been in a FHO for about a year, and his work covers the full scope of family medicine, including palliative care and rural emergency medicine. You might also know him as the creator of the NextGenMD YouTube channel, where he shares helpful content about family medicine and starting a medical practice in Ontario. Dr. Calcagno, welcome.
Thanks so much for having me. Really appreciate it.
So to get started, can you tell us a bit about your current practice?
Yeah, so right now I'm located in the Niagara region. My main office is in Welland, and it's been a full year as of July. I'm currently working, it's about 5 to 6 days per week. So I'll do 4 days in office, 9 to 5 usually. Then I'll do some home visits after that. And then I do either a 24-hour emerge shift or a 12-hour emerge shift on the weekends 3 times out of the month. And then I do some palliative medicine as well, some home visits. And it's full scope family medicine. It's what I wanted to do.
And what was your experience like starting out with the faux model?
It's interesting. So I can't see who I'm talking to right now, but I imagine there's a whole bunch of doctors and other people that have varying degrees of experience joining us today. And my experience in the first year was that it was hectic. And I'm sure a lot of you could remember the first year in your practice as well. I think my education here in Canada was great. Between all the exams and everything, I felt prepared to start practicing. But then when I actually started, especially in my area here, there was a bit of a physician shortage, and a lot of patients just hadn't seen a family doctor in a very long time. So we had a lot of high acuity from the get-go, and a lot of people that needed a lot of work done in the beginning. So I tried to stagger the enrollment process as best as I could, but we were immediately flooded with, more than 1,000 applications the first month that we were open. So it's been a learning curve, to say the least.
Sounds like it. And could you tell us a little bit about why you chose the faux model over the other physician enrollment options that were available to you?
Definitely. So first, just a disclaimer, I joined the FHO. I didn't have to start a FHO myself, thankfully.
Mm.
The FHO that had already existed, and I had known a few of the doctors before because I had known them from either being a preceptor when I was still a resident, or from other places as well. And this is a financially geared presentation today. I'll say that on the one hand, joining a FHO does allow me for continuation of care in a way that I wanted to practice. On the other hand, after crunching some of the numbers myself, I saw that it is one of the most lucrative options to practice the way that I wanted to practice, and at the same time, still allowing me to do emerge because I wouldn't consider myself a full-time emerge physician, but it is something that I really do enjoy. It allowed me a good spot to be able to do both.
Okay. And what would you say were some of the key challenges that you faced during your first year of practice?
Almost all of them, almost, was related to the management of the time and the roster and the billing. Um, uh, as soon as you sign up in July, first off, so as you had said before in a previous slide, the full application doesn't go through for a couple of months when you first enroll. So trying to understand which codes to bill and who to enroll and who not to enroll and kind of forward messages to yourself were some of the administrative burdens that I think Doctor Care really was able to help me out with. So that's why I sought them out in the beginning. And I would say just because they were a big help in the first year, it's instrumental. I do recommend the Doctor Care services to many different people. Outside of that, it was just trying to provide timely care for people that had been neglected for so long was another one of the challenges that I faced.
And, in terms of the roster that you alluded to, how did you approach building and managing your patient roster?
Yeah, so thankfully in my area, good and bad, we didn't have to do any advertising. It was kind of word of mouth. So we had all these applications. And I have some really great staff here that work at the office from a receptionist field, and then also some other doctors that had been working in the FO for a while as well. So I tried to operate on a first come, first serve basis in the beginning. And I did that for about the first 500 patients. And then it became very clear that some people were going to need way more help than other people. And in that case, what I tried to do is just be honest with the people coming in. How quickly did you need to see me? Over the course of the first year, I've constantly tried to have my receptionists just let people know when they come in what our waiting time was like. And I think the longest wait time at one point was about maybe 4 months to get in for that first meet and greet visit. I wanted to bring everyone by for a meet and greet visit. And then after that, it was just a matter of, thankfully, I was working with Damien, who's one of the doctor care administrators, and he was a big help in terms of we met on a once a month basis just to discuss which codes I was doing, which ones I had been neglecting, which ones I needed to read into a little bit more. And then also accessing the support line through doctor care as well was really important. But I tried to enroll as many people as possible in terms of people that had come to see me, but then trying to manage as well who is using the walk-in clinics in the area at a high frequency. And that part of roster management is very difficult. So that's something that I rely on Dr. Care a lot to help out with. I think that one of the most difficult parts of the last year is that I need to open as much free time in my own schedule as possible to actually see people. So anything that I could do to cut down the administrative burden is something that I was really interested in looking into.
And on the actual billing front, like how have you managed the billing aspect of your practice so far?
Yeah, it's something that I have to stay on top of every single night. So what I do is I cut my day up into two different blocks and I'll print out a day sheet. Many of you might do the same. And I'll try and have my notes caught up with every single patient. So usually if you see someone for, let's say, 20 minutes, then I'll take a 5-minute block afterwards to try and finish all my notes. And then also write which code is applicable for that visit, whether it's a diabetes, KO 30, or if it's just a general counseling, a KO 13. And in that sense, at the end of the day, I'll sit down for half an hour and I'll put in all my codes through PS Suite, which is what I use to do my charting and my billing. But trying not to fall behind, I'm sure, is one of the challenges for all of us.
Completely understandable. And I know you've alluded to bits and pieces of where Doctor Care has stepped in. Can you share more about your experience working with the Doctor Care team?
Definitely. The medical education part of my training was awesome. The business part of my training, and I don't think it's specific to me, I think it's something that we don't talk enough about in medical education here in Canada, was definitely lacking. And even speaking to some of my co-residents that are now practicing, trying to get the most value out of the time that you spent so that you're being paid fairly for the services you provide. And it was great being able to ask, hey, when does the KO13 actually apply? And when is it an A007? Can I combine a KO13 with an A007? What can I combine with a diabetes visit or not combine? Anything about smoking cessation? One of the things I try and tell students that come and talk to me, medical students, residents as well, is trying to learn the billing codes inside and out. Early on in the first year, in my experience, is hopefully going to set you up very well for the long term. So Dr. Care was instrumental, even just booking consults once a month to talk with Damien or whoever was helping me that day. I'd keep a list of all the questions that I had. How do I bill a PAP properly? How do I bill an endometrial biopsy? How do I bill my home visits? That was a tricky one in particular because there's a whole bunch of different rules with home visits. So in my first year, I don't know if I would have been able to get the same value for my actual services unless I had someone helping me out.
And on that note, have there been any specific billing insights or tools that have helped you optimize your earnings within the FHO model?
Definitely, for sure. To any of you that are going to be doing home visits, I personally think that it's a good service to offer for people that really need it. And in my opinion, you do get reimbursed quite well for it. For a 20-minute visit, you would go ahead and bill a KO23 plus your premiums for actually going to someone's home. And then if they are of a nature where they are truly palliative and you're going to be the most responsible physician for them, then adding on the G512 code as well. And in that sense, again, kind of comprehensive billing, but also comprehensive care for the patient too. The other big one was the KO13, which is an in-basket code, but the name of the game in a FO is to maximize the out-of-basket codes. So I'm sure many of you know that your patients don't all require the same amount of care. There are patients that I see 3 times a month, and there's patients that I haven't seen since my meet and greet. So being able to, from the very beginning, understanding who needs what help and maximizing those KO13s if I had gone beyond 20 minutes for counseling with them, and now being able to benefit from the KO33 code afterwards, which is out of basket. I think that's a big tip that Dr. Care helped me out with in the beginning.
So you run a YouTube channel. How would you say that's influenced or supported your journey as a physician?
I think so many of us like to give back to the new generation of students that are trying to be doctors as well. One of my biggest personal crusades was just I love being a family doctor a lot. It was the career that I chose amongst everything. So it was my first choice. And seeing some of the trends in where the medical students are going, where interest lies, and seeing that sometimes family medicine is becoming less and less appealing to many different students, this was my way to give back in a teaching role, without needing to do things like through multiple universities. We might be able to do like clinical skills or facilitating with exams. This was a direct approach. I got to influence, I hope, many people to make decisions on what they truly wanted to do. And I got to take some questions in the comments as well. And it really helps you to build a thick skin in your first year of practice when because the internet's open, so people can say whatever they want in the comment section. So you really learn to handle public relations better. And I think that helped me in my job too.
And last and not least, what advice would you give to physicians who are just starting out in Ontario?
It's such a hard question because I don't think there's one answer for how you can do it. You have to know what you want out of the job and what type of personality type you have. If you have kids, if you don't have kids, what your plan is. I think overall, I work a lot. And I've noticed that in the last year, but this was always the plan. This is something that I wanted to do. So when I realized that a lot of my friends were going into a general surgery residency, or maybe they want to pursue cardiology, well, you get out of medical school and then you do your residency, and that's 5 years, 7 years, depending on what people want to do. Thankfully, I got a great education in my residency. I felt very comfortable to be able to practice after the 2 year family medicine residency. But my goal was to work like I was still in residency in terms of hours put in so that I could maximize revenue, maximize learning about the business aspect as well. And that's what I'm doing right now. I'd say for anyone that's ready to hit the ground running, first of all, it's what we need. It's what medicine needs right now. We need people to actually do the work. And at the same time, you're only setting yourself up for success. So I can't say that that's going to be something that everyone's going to be able to do, but know yourself and know where your interests lie and go in that direction. And if you feel like you are that person that wants to be the general practitioner that does everything, I've had a great time with it so far, and it can be done.
That's great. Thank you so much, Dr. Calcagno, for your time today.
At all. Thanks for having me. Take care, everyone.
Moving on to our next section, let's discuss roster management, an integral component of running a faux practice and one of the most challenging ones. The Ministry of Health recommends that each patient be enrolled or rostered with a family physician. Being rostered helps strengthen the doctor-patient relationship and maximizes your capitation. However, you may often encounter discrepancies between the patients you think are enrolled and those rostered to you by the ministry. In many cases, the ministry's roster count is lower than what's shown in your EMR. And this mismatch can happen for several reasons. Patients accidentally rostered with another doctor at a walk-in clinic, rostering codes, the Q200 or the Q202 were rejected or never submitted, and patients falling off your roster without them knowing it. Making sure you identify and reconcile these discrepancies is critical. It ensures that you're providing optimal patient care and receiving the compensation you're entitled to. So, what are the best practices for roster management? First and foremost, to effectively manage your roster, you need to continuously review your roster list and compare it against the list enrolled to you via the ministry. Additionally, ensuring your roster is of proper size and composition can help you build a roster that meets your personal goals. And finally, by regularly reviewing your error reports for Q200 claim errors, you can correct and resubmit the claims to ensure the patient is in fact added to your roster. So, how do you roster a patient? To enroll a patient into your roster, you would submit the Q200 code or the Q202 for long-term care residents, along with the signed enrollment form, and submit it to the ministry. As a faux physician, you earn approximately $200 per rostered patient annually, and $1,200 for long-term care patients. There are also a few rostering incentive codes, the Q023, which is the unattached patient fee, the Q043, which is the new patient FOBT positive fee, and the Q053, which is the complex vulnerable patient fee. If you have patients who fall into these categories, it's good to be aware that you want to build these incentive codes with the Q200 to get the premium payment. Furthermore, rostered patients have additional benefits to FHO physicians, such as submitting specific billing codes, triggering bonuses, and contributing towards preventive care incentives, which we will dive into later. To further illustrate the impact that effective roster management can have on your revenue, let's examine an example of a physician we recently assisted. A doctor signed up with us with a roster of 1,300 patients. We conducted an analysis and identified 250 patients who were not assigned to this doctor by the ministry. We sent out rostering forms to the patients, and within the first 2 weeks, we received 60 of the rostering forms back. That's about $12,000 increase in revenue that the physician received from that one round of forms that we sent out. After that, we sent out another round of forms and again received 20 forms this time around, so about $4,000 in revenue. In total, the physician rostered 80 patients within 1 month and received about $16,000 in additional annual revenue for the rostered patients. Therefore, as you can see, effective roster management is extremely important in the FHO model and is key to maximizing your practice efficiency and revenue. Now, let's move on to special premiums and bonuses. FHO physicians can earn additional revenue through bonus structures, some of which we briefly touched upon earlier, and all of which contribute to the average 18% increase in annual revenue. Here are the main bonus categories FHO physicians can benefit from: access bonus, special premium bonuses, and preventive care. Now, let's go deeper into what each of them is and how they affect and benefit FHO physicians. The access bonus is an additional incentive based on your roster size that Ontario doctors receive if their patients do not seek care outside of their FHO group, such as at a walk-in clinic. One common misconception is that you're losing your income every time your patient goes to the walk-in clinic. That is not correct. You're actually losing out on the bonus potential. You're not losing anything from your actual day-to-day payment. When an enrolled patient sees a physician outside of their FHO group, this is what is referred to as outside use. As the access bonus is a group-level payment, it may be impacted by other physicians in your FHO. You will not accumulate outside use if a patient sees a physician in your FHO. Maintaining a strong patient-physician relationship is crucial, as doctors can be penalized if their patients frequently seek care elsewhere. This is why in a FHO, you are required to provide after-hour care so you can minimize the amount of outside use you incur. For strategies on managing outside use, we have created several helpful resources, which can be found in the resources library and the blog page on the Doctor Care website. Essentially, you'd want to remember this. The less frequently your rostered patients seek outside care, the higher the access bonus you'll receive. Physicians receive this bonus twice a year, in April and October, and will receive approximately 20% of their overall monthly capitation before patients seek outside care. Finally, let's touch on special premium bonuses. This is another income stream that enables FHO physicians to receive additional payments, in addition to their regular fee codes for providing care in specific categories. These categories include hospital services, labor and delivery, palliative care, home visits, prenatal care, long-term care, primary care, serious mental illness, and office procedures. To claim the bonuses in each category, physicians would need to bill specific codes at a certain minimum for their patients. To help with this, we have a guide on the eligibility requirements for the different categories available in our website resource library. Not every single one of you is going to provide care in all of these categories, and that's perfectly fine. The three categories that we see the most are office procedures, prenatal, and serious mental illness. Please note that we do not recommend trying to attain all of these categories merely to increase your income. However, if you are contemplating a transition in your future and perhaps reducing your office hours, you might want to consider pursuing some long-term care work or home visits, as there is a significant potential in that area. To understand more about how to claim your bonus, let's take the hospital services bonus category as an example. If you are a FHO physician with hospital privileges, you can receive an additional $5,140 when you bill at least $2,000 in eligible hospital codes listed on the slide to enrolled and non-enrolled patients. Physicians bill the eligible codes during the fiscal year, which is from April 1st to March 31st, and will receive the bonus once per year. Lastly, doctors can expect to receive a yearly preventive care bonus. The preventive care bonus is a financial incentive for eligible family doctors who provide timely and regular preventive screening and immunization to their rostered patients. The bonus covers 5 preventive care categories with specific age and interval requirements: influenza vaccine, pap smear, mammogram, colorectal screening, and childhood vaccines. For FHO physicians specifically, there's been an important change to the preventive care bonus. You're now eligible for bonuses in just 2 categories: childhood immunization and influenza. Pap smears, mammograms, and colorectal screening are no longer included. With these updates, the maximum bonus you can earn is $4,400. These changes aim to repurpose funding towards supporting complex patient care through the introduction of the acuity modifier. With the ministry's decision to discontinue preventive care bonuses in 3 categories for FHO physicians, this change has sparked ongoing conversations across the medical community. To help offset the impact, the OMA introduced a new acuity modifier payment structure. This new model is designed to redistribute the funds and ensure physicians continue to be fairly compensated for the care they provide to complex patients. This payment is based on the patient's diagnosis and not the services provided to the patient. The new system works by calculating a patient's risk score based on factors like age, sex, daily living activities, and health conditions, using the Canadian Institute for Health Information's population grouping method. Each patient is then placed into an acuity band from band 1, least complex, to band 5, most complex. The higher the band, the greater the compensation, reflecting the extra time and resources needed to care for more complex patients. It is important to note that the ministry is responsible for assigning patients to their respective bands, not you. As a physician, your role remains unchanged. You'll continue to submit claims as usual, making sure to include the correct diagnosis on each claim. Try to avoid using generic diagnostic codes. Using accurate codes helps reflect the true complexity of your patient's care. You may be wondering, after everything we've talked about so far, how can I keep track of my roster, check if I've been paid my bonuses, and manage outside use and billing errors? A key aspect of optimizing your income as a physician is through your monthly reports. Each month, you will receive detailed files from the Ministry of Health that show the claims you have submitted, what's been paid, what's been rejected, and the status of your bonuses. However, these reports are often lengthy, complex, and difficult to interpret, making it challenging for physicians to identify potential issues in their billing. Let's look at some of the key reports that will come through your EMR. Starting with the remittance advice report, this report lands in your EMR within the first few days of the month, and it lists all the claims you submitted that were approved or paid with adjustments from the previous month's cutoff date. You will see codes like I2, which means services is globally funded, and those services were paid at the shadow billing rate. In Ontario, The ministry's cutoff date for claim submissions is the 18th of every month, unless it lands on a weekend or holiday, for which it is the next business day. Claims submitted by the cutoff date will be paid the following month on the payment date, which is usually the 14th of every month. The RA report also shows you how much you can expect to be paid for that month, as well as tracks your special premium bonuses, preventive care bonus, and displays updated capitation rates, which may change periodically. You can easily identify this report as it starts with RA. Another report that you will see come through from the ministry is the error report. The error report lists all the claims you have submitted that have been rejected or refused. Each claim on this report will have a corresponding 3-character explanatory code. For example, you will likely see the EH2 error code, which indicates that the patient's health card version code has expired and therefore the claim cannot be paid. When it comes to outside use, many physicians wonder how they can determine when their patients have sought care elsewhere and for which in-basket services. You can find this information through the outside use report, which can assist you in calculating your potential access bonus payment. In this report, you can view which patients have visited outside your clinic, along with the dates and services they received. The file name for this report starts with L, letter, OU. Lastly, we discussed how effective roster management is essential for keeping your FHO practice running smoothly. As part of this is reviewing your roster activity each month to stay on top of any changes. To help with this, the ministry sends out a roster and capitation payment reconciliation report. That contains a list of all of your currently rostered patients, along with the number of patients, as well as any roster activity that occurs in the month, such as rostering and derostering, start and end dates, and adjustments to capitation. Now that we've covered the major components of a FHO model, we also want to highlight a program available to help eligible physicians as they start their practice in Ontario, which is known as the Income Stabilization Program. Did you know that you can get financial support when you first join a FHO? The Income Stabilization Program, developed by the Ministry of Health, provides financial support for physicians who have joined a FHO or a FIN while they develop patient rosters prior to converting to the group-based blended capitation model. This means that you'll receive a guaranteed payment for up to 12 consecutive months when you join a FHO or FIN, as long as you meet your monthly enrollment targets. So, what are the criteria required to be eligible for the Income Stabilization Program? First, you can only apply within 3 years of your graduation date. After that period, you will no longer qualify for the Income Stabilization Program and will instead be transitioned to a signatory member. In addition, you must not currently be part of any patient enrollment model, including FHO, FIN, FIG, or CCM, or have a current roster. You can only join within your first year of fee-for-service billing in Ontario and are not taking on any number of patients from any other provider. Lastly, you can only use the Income Stabilization Program once. So if you have already participated before, you are not allowed to register for the program again. Please note that some exceptions may apply, so feel free to contact us if you have any questions. As we wrap up today's session, let's take a moment to go over some key takeaways. So what does all this mean for you as a new physician in Ontario or someone considering the FHO model? It means there's a real opportunity to set yourself up for success by joining a FHO. First, you'll get predictable income. In fact, on average, 80% of FHO income is guaranteed, no matter how many patients you see. Second, there's the potential to increase your earnings. FHOs offer extra revenue opportunities through additional special premiums and bonuses. Third, you'll have better work-life balance. That's because FHOs provide shared on-call coverage, so you're not on your own for after-hours care or when you take a vacation. And lastly, the FHO model helps you focus on providing quality care, not just trying to squeeze in more patient visits. So if you're thinking about starting or growing your practice, the FHO model in Ontario is a great place to begin. As a thank you for attending today's webinar, we would like to extend this exclusive offer to all our webinar attendees. If you are looking to establish or join a FHO or interested in learning more about the income stabilization program, we can help. At Dr. Care, we have successfully formed over 50 FHO groups across Ontario and registered more than 100 FHO doctors with the Ministry of Health. We're here to help make your transition seamless and rewarding. Today, we're offering you a complimentary income analysis to determine if joining a FHO is the right fit for you. Simply email us at info@drcare.ca to request a consultation with our team. Additionally, as a thank you for attending our webinar, all participants will receive a free copy of our 2025 OHIP billing guide via a follow-up email. So make sure to keep an eye on your inbox. Now, we'd like to open the floor for your questions. Please feel free to submit any questions you have using the Q&A feature, and we'll try to answer as many as we can. So we have a question with regards to size of the FHO. So what can the FHO do as a group to maximize the access bonus? So that's a great question. FHO groups can maximize their access bonus by ensuring patients have adequate access, as well as educating them to avoid seeking care from outside physicians. This means being diligent about informing patients of clinic hours and after-hours schedules as a group, as well as derostering patients with excessive outside use. So we often get questions about rostering and derostering, so I'll answer two over here for the audience. So how can I determine whether or not I should deroster a patient as a physician? So if you notice that a patient is consistently using walk-in clinics for core services, accumulating significant outside use, typically that's when we recommend that you deroster the patient. And then with regards to whether you need to communicate with your patient if you deroster them, now that is entirely your decision. You don't need to inform your patients that you must deroster them, as you are going to continue providing care. However, depending on your clinic's policies, you may want to inform them of any scheduling limitations. And then I'll take the last question for the day. Yes, this we definitely hear. So your rostered patients that were seen at a hospital, why are they accumulating outside use? So this is actually a very common question we see from physicians. So some physicians may not be aware that many hospital codes are actually in basket, and therefore, if a patient is seen for those services in a hospital, this will be applied to your outside use. So unfortunately, in situations like this, the outside use is inevitable. That is the end of our webinar. On behalf of Dr. Care, thank you so much for joining us today. If you have any questions or have any feedback on the webinar, please feel free to contact us anytime. Our contact information is listed on this slide. Have a wonderful day.